Thank you, AJ. Dear colleagues and friends, it's my privilege to make a few concluding remarks at the end of the symposium. And of course, I'm not going to restart from scratch. I'm not going to re-explain everything. You have got fantastic speakers. I just want to pinpoint some ideas that were put forward during this symposium. I have no disclosures. You have seen that already, no need to expand on that. The very good news, as pointed out by AJ, by Freg, that the ESC anticoagulation therapy rate rose from 57 to 71% during the course of the registry. This is what is called the registry effect. It is known that one clinician participates in a registry, then they improve their way of treating the patients. And NOAC uptake is tenfold higher at the end of the registries. Is absolutely dramatic improvement, and this is good for the patients. The most important messages are probably here. Death is the most frequent adverse event in atrial fibrillation patients, occurring at a 3-fold higher rate than stroke systemic embolism and 5-fold higher rate than major bleeding. And similar rates of cardiovascular and non-cardiovascular deaths, you have seen that repeatedly. But if you list by order of rate, the comorbidities that are associated with the worst outcome in terms of death are congestive heart failure, malignancy, infection sepsis, respiratory failure, and sudden death. Among the most frequent known causes of death, some deaths are, we don't know that. But the most important to me is here. If you look overall, stroke is accountable for only 5.5% of all known causes of death. And this strikes the imagination of clinicians. They say, how could it be? Simply means that stroke is not the leading cause of death for many reasons, and particularly because the patients are adequately treated with anticoagulants. No doubt anticoagulation has an impact on the risk of stroke and an impact on the risk of death from stroke. But a figure was not shown during this symposium. The risk reduction achieved by anticoagulation in GARFIELD. Risk of death, 36% less risk of death with anticoagulation compared to patients with no anticoagulation. Definitely anticoagulation has a major impact, but not through reducing the risk of stroke per se. Most probably anticoagulation has an impact on the risk of death through other mechanisms, particularly prevention of pulmonary embolism in cancer patients, in heart failure patients, in patients with sepsis, etc., etc. And not to mention that the new oral anticoagulants have now a demonstrated efficacy on the recurrence rate of events in post-acute coronary syndrome patients. In other words, there are other mechanisms that prevention of stroke that may explain the reduction of death linked to the use of anticoagulants. Sam Goldhaber stated, is AF primarily a risk factor or risk marker? And he answered the question, AF is definitely a risk marker for systemic disease and a risk factor for stroke. And he said, the first mission in AF patients is to prevent stroke. We cannot agree more, but management of systemic disease is equally as important because stroke is accountable for a limited number of deaths. So we have to concentrate on the comorbidities on so-called systemic disease. They are listed here and no need to expand. Just, for example, congestive heart failure, 20%, history of coronary artery disease, 21%, moderate to severe chronic kidney disease, 11.7%, etc., etc. So high rate of comorbidities in GARFIELD registry. Other messages, women have higher risk of stroke. We just talked about that, no need to expand. Obesity paradox is confirmed in GARFIELD-AF, and you may know more in poster number 87116 on Monday. If you want to know more about the obesity paradox, you can direct your question to John or see the poster on Monday. Other very important take-home messages. Congestive heart failure is associated with a dramatic impact on all three major outcomes and measures, including major bleed, particularly New York Heart Association classes 3 and 4. And again, there will be a poster on Monday, 85662. You want to know more, go to this poster. The same is true for CKD patients, particularly those with moderate to severe renal impairment. No doubt, congestive heart failure and chronic kidney disease are nasty diseases and impair severely the outcome of AF patients. And AF patients with a history of acute coronary syndrome suffer from a high rate of recurrence events and deaths. And perceived bleeding risk may lead to non-anticoagulation and also the concept of polypharmacy. You are physicians, and you know that very often you are hesitant. Should I add yet another drug on a list of already 6 or 7? That's a dilemma that the clinicians live on a daily routine life. Last message is, the rate of anticoagulation is suboptimal in the sickest patients, irrespective of the comorbidity under consideration, but to a lesser extent, and surprisingly, to a lesser extent in chronic kidney disease patients, as shown by Shinya. And in addition, generally speaking, it was just pointed out by both Keith and again by Verhulst, up to 2/3 of patients have no antithrombotic treatment at all after 4 months, but anticoagulation rate remains stable. This is surprising, it's a fact. I was surprised, the first to be surprised with this, to see that no antithrombotic therapy at all after 4 months. And this is true also for patients without heart failure, without acute coronary syndromes. And I referred to that already, but this is needed to stress over and again. The comorbidities associated with the worst outcomes in atrial fibrillation patients, namely congestive heart failure, vascular disease, chronic kidney disease, are suboptimally treated in not almost, but roughly 50% of the cases as regards the rate of prescriptions of guidelines recommended drugs for the very specific condition under consideration. And this is where we have to be fighting if we want to improve the outcome of our patients. And this is not beyond reach. And the best evidence was reminded to us by Lorenzo, who quoted the paper by Chatterjee and co-workers, showing that integrated care may result in improved outcomes. So we have to be very aggressive as regards treating comorbidities. And to summarize, we have seen this kind of diagram many times, no need to expand. We have to treat the patient as a whole. And we should not be satisfied in simply prescribing anticoagulants, going for rate or rhythm control. This is what we have to do with atrial fibrillation patients, no doubt, but we cannot forget what is around. In other words, all the comorbidities and number one, congestive heart failure, for example, but not only. Thank you very much for your attention. I take this opportunity to thank the physicians, nurses, and patients involved in GARFIELD registry. Thank you, and have a good meeting.